Good day once again, my fellow YouTube viewers. I am Dr. Simpiwe Siko, currently employed by the South African Military Health Services, and today I'm going to be talking about Appendicitis Inflammatory Response score in the diagnostic workup of acute appendicitis. This is an addition to some of the videos that I've made about acute appendicitis and clinical scoring systems. You can check this out in my YouTube channel, Dr. Siko's Room. As I've already mentioned, Appendicitis Inflammatory Response score, together with Alvarado Score, Adult Appendicitis Score, Repasa Score, Pediatric Appendicitis Score, are clinical scoring systems that are used in suspicion of acute appendicitis. The Appendicitis Inflammatory Response score is considered to be superior than the Alvarado score and also better performing than the Alvarado score. Once a score has been calculated for a patient, the clinician can then decide on three things: whether to discharge the patient, whether to perform further imaging tests, or whether the patient needs urgent surgery. So these scoring systems will help the clinician to decide on that. So now let us compare the AIR score to the Alvarado score. The Appendicitis Inflammatory Response score, in contrast to the Alvarado score, has only got one symptom, which is vomiting. You call to mind that the Alvarado score had three symptoms, which was migratory, right iliac fossa pain, anorexia, nausea, or vomiting. So, to reiterate, the Appendicitis Inflammatory Response score has only got one symptom, in contrast to the Alvarado score, which has three symptoms that are here listed. Now, with regard to the right iliac fossa tenderness, in the AIR score, right iliac fossa tenderness is given 1 point. You remember that right iliac fossa tenderness was given 2 points in the Alvarado score. Now, rebound tenderness is differentiated in the Appendicitis Inflammatory Response score according to severity. Light muscle defense is 1 point, medium muscle defense is 2 points, and strong muscle defense is 3 points in the AIR score. There was no differentiation in the Alvarado score. We just spoke of right iliac fossa rebound tenderness, and 1 point was allocated for this. When with regards to fever, in the AIR score we refer of high-grade fever, which is still given 1 point, but in the Alvarado score they spoke of a low-grade fever, which was also given 1 point. So the fever is still given 1 point. It's just in the AIR score the fever is high-grade, and in Alvarado it was low-grade. The polymorphonuclear leucocytes predomination is differentiated in the AIR score. So polymorphonucleocytes nuclear leukocytes predomination of 70% to 84% in the peripheral smear are given 1 point, and 85% of predominance in the peripheral smear is given 2 points. I'm still talking about polymorphonuclear leukocytes in the AIR score. In the Alvarado score, left shift was given 1 point and defined as 75% or more neutrophils. The leukocytosis in the Appendicitis Inflammatory Response score is also differentiated. Leukocytosis of 10 to 14 is given 1 point. Leukocytosis of 15 or more is given 2 points. The Alvarado score did not differentiate its leukocytosis above 10,000, which it just gave 2 points. So this is another difference. Also, the C-reactive protein was added to the AIR score, which was not there in the Alvarado score, and the CRP value of 10 to 49 is given 1 point, and a CRP value of 50 or more is given 2 points. Note again, there was no CRP in the Alvarado score. The total possible score in the AIR score is 12 points, and the total possible score in the Alvarado scoring system was 10 points. Now we're going to look at risk stratification of patients. Patients are stratified into 3 risk groups: low risk patients, intermediate risk patients, and high risk patients. Low risk patients scoring 0 to 4, intermediate 5 to 8, and high risk patients 9 to 12. This risk stratification helps the clinician as to which steps he must take with regards to the patient care. So low risk patients, there is a low probability that these patients have gotten appendicitis. In other words, this low risk probably excludes appendicitis, and these patients can be discharged and return if symptoms don't stop. Intermediate risk group patients need further imaging. High risk group patients need surgery, and imaging should be omitted in them. I'd like to thank you for once again viewing this video and visiting my channel, Dr. Siko's Room. So if you found this video to be useful, please let the people like, let the people share, and let the people definitely subscribe. Once again, I thank you.